Hi, I am Dr. Felice Gersh, your integrative OBGYN. And for this episode, I'm going to talk with you about a very important subject, thyroid function and menopause. Now, it is so complex that I can't possibly cover it all here, but at least we can cover some of the key issues. First of all, it is really important to know that the issues of thyroid disease really escalate during the menopausal years and all the years thereafter. In women who are going through menopause, there is an increased incidence in hypothyroidism. There's also elevations of thyroid cancer, thyroid nodules called goiters. Autoimmune thyroid also is very prevalent, both Graves' disease, which is hyper, and Hashimoto's, which is hypo. So recognizing that thyroid disease is very prevalent and increases during the menopausal transition and the years thereafter is essential, because many of the symptoms that women experience as they transition into menopause and thereafter have a lot of resemblance. In fact, some of them are identical to the symptoms of thyroid disease. For example, women often through menopause will have sleep disturbances, mood problems, weight gain, sluggishness, brain fog. They will often feel chilly or get kind of dysregulation of their temperature. And as I mentioned, weight gain is so prevalent. Now, most women think weight gain is hypothyroidism, but during the menopausal years, a lot of doctors aren't thinking that way. They're thinking it is from the menopause. And in fact, it has been studied, and many women who have very, very blatant symptoms that could overlap between menopausal symptoms and hypothyroidism are not tested efficiently or even at all for thyroid diseases. In terms of hyperthyroidism, women with hyperthyroidism will often have night sweats and hot flashes, mood disturbances, which are, of course, very common in women who are going through the menopausal transition and thereafter. So it's really important for you, if you're a consumer of healthcare and if you're a physician, to be really cognizant of the fact that women around the menopausal years and thereafter have such high rates of thyroid diseases. And as I mentioned, thyroid cancer, thyroid nodules, thyroid fibrosis. Now, when I say thyroid fibrosis, it's really important to know that as you age, every organ in the body is aging, including the thyroid gland. So it tends to be less efficient. Now, why does that matter in menopausal women? Why do women have more hypothyroidism than men? It turns out that there are estrogen receptors on the thyroid gland. In fact, it's way more complex than most doctors even know. There is a real interplay, an interconnection between sex hormones, particularly estradiol, and thyroid hormones and thyroid function. So it turns out that there are receptors on the thyroid gland to estrogen. When estrogen production is reduced during the menopause, thyroid function will decline just from that. And then couple that with the aging process where thyroid glands they get smaller. They just age like everything else in the body seems to age. And you have decreased thyroid production. So this is really important. On the other hand, there are thyroid hormone receptors on the ovaries. Now, this becomes less significant when you're going into menopause, because what am I talking about? Well, you're not going to make any hormones from your ovaries as far as estrogen and progesterone goes after menopause. But before menopause, during the transition, the perimenopausal years, it turns out that the fact that thyroid hormone has receptors on the ovaries and actually has a huge impact on all aspects of reproductive function, including ovarian hormone production and the menstrual cycle. The whole cycling routine and ovulation is incredibly dependent on having optimal thyroid function. It turns out that women who have low thyroid, for whatever the reason, most commonly in the premenopausal years due to Hashimoto's or autoimmune thyroid, low thyroid, for whatever the reason, is associated with an earlier onset of menopause, which is very detrimental. So even in the premenopausal years and perimenopausal years, it's really important to have optimal thyroid hormone present to help maintain ovarian function and function properly for as long as is possible, because of this incredible interplay between thyroid gland, thyroid hormones, and all of reproductive functions and the ovaries. In fact, in terms of the reproductive years, now it's finally recognized that it's essential to have optimal thyroid hormone production, and that is looked at by the TSH level. But of course, those of us in functional and integrative medicine don't just look at TSH. I'm going to go over a little bit thyroid testing in a moment. TSH then stands for thyroid stimulating hormone. That is a hormone that is produced by the pituitary gland in response to the signals coming out of the hypothalamus of the brain to tell the thyroid gland what to do through the thyroid TSH, and through the ovaries. Of course, there's a communication from the brain to produce ovarian hormones, and there's an incredible interplay here. So it turns out that all of these systems are completely interconnected. When you don't have the right amount of thyroid hormone, you don't have proper ovulation, you don't have proper sequence of hormone production. So during the perimenopausal years and premenopausal years, it's essential to have proper hormone production. In terms of TSH levels in women that are trying to conceive, the levels should be somewhere between 1 up to 2.5, which is different from what endocrinologists say is an appropriate level of thyroid stimulating hormone during other times of life. But in the pregnancy years, when you're trying to get conceptions, or during pregnancy itself, that's when it's monitored more strictly. In my opinion, why would you only want to have an optimal thyroid hormone production during the years that you're trying to conceive or during pregnancy? I say we should strive as much as we can to optimize TSH and thyroid production throughout life. So it's recognized finally, as I said, how important thyroid hormone is, an optimization of thyroid function for proper fertility, conception, and pregnancy. Well, it matters at every stage of life, and menopause makes things more complex. So now you know there's this interplay between the thyroid gland and the ovaries. Well, it turns out that estrogen, which of course is not going to be produced naturally from the ovaries after menopause, and you know I'm a big proponent of hormone therapy, both perimenopausal as hormone supplementation and in the menopause as hormone replacement, because it turns out that estradiol is really important for the function of thyroid receptors. Not only are there receptors on the thyroid gland itself for estrogen in the form of estradiol in order to maintain proper functionality of the thyroid gland, but to maintain proper function of the thyroid receptors, you need to have optimal amounts of estradiol as well. So without adequate amounts of estradiol present in the body, the thyroid gland won't properly be able to make enough thyroid hormone production will go down, and the thyroid that is produced won't work optimally because the receptors will not be optimized in an absence of adequate estradiol being present. That is why it is so important to understand how this is a very big deal. Now, what does thyroid do in the body? It maintains metabolism, the production, utilization, storage, distribution of energy. It's essential for the structure and function of virtually every organ in the body. And the brain will not function properly without the right amount of thyroid present. In terms of complexity and the interplay, it turns out that thyroid itself, thyroid hormone, can actually bind to estrogen receptors. It's so complex that even if you have thyroid present, it can actually directly affect estrogen receptors. So the interplay between these two structures, the thyroid gland, the ovaries, is so immense, it's so complex, and it's so important to have the right amount of thyroid function in order to maintain proper reproductive function, and to have proper estrogen present to maintain proper function of the thyroid gland. So after menopause, we can't worry about having proper reproduction because there is no more reproduction, but we sure can be concerned about maintaining optimization of estradiol levels for functionality of thyroid receptors and the thyroid gland itself. And now it gets even more complicated because it turns out that when you lose your estrogen and progesterone, you alter the gut microbiome very rapidly. And this has been studied. Women in menopause have an altered microbial population in their gut. And the gut microbiome turns out to be a producer of all kinds of products, vitamins, peptides, neurotransmitters, hormones. I mean, it's like a major factory going on in there. And they make metabolic byproducts of fermentation, the short-chain fatty acids that help regulate liver function, brain function, the autonomic nervous system. All of this changes when you go into menopause if you don't have adequate hormone therapy. And when that happens, not only do you create more leaky gut, which creates inflammation, which can then affect thyroid function directly by creating inflammation affecting the thyroid gland, but as well you'll have alteration of digestion. And you can develop micronutrient, even if you're eating properly, which many people don't, micronutrient insufficiencies. It turns out for thyroid glands to make adequate amounts of thyroid hormone, which is T4, and for the conversion of T4, which is the storage form of thyroid, in order to convert it properly to the active form, which is T3, you need certain micronutrients. So you need certain ones to make thyroid hormone, T4, and to convert T4 to the active form, which is T3. So just so you know, 80% of all the thyroid in the body is T4, the storage form. Think of it like money in your savings account. It is there for when you need it. And 20% of the thyroid is T3. It has one less iodine, okay? And that is really critical. That's 20%, and that is like your cash in your wallet. That's what you spend. That's the thyroid that's active. And this is really critical to have the right balance. So you need to have the following micronutrients. You need, and there's more, but you need to have iron. You need to have zinc. You need to have selenium. You need to have iodine. You need to have a whole host of different micronutrients in order to make thyroid in the first place and convert it properly. You need to mention copper. So you need to have a whole selection of these micronutrients. If you do not have enough of even one, you're not going to have proper thyroid hormone production. And that's why I measure micronutrient status in so many of my women who are not doing well, or if they are not getting the right amount of conversion from T4 to T3. Now this gets into treating. This is really important. So in order to treat, you need to first measure. You need to know what are the thyroid hormone levels that are present. So the test that you want to ask your doctor to order would be TSH, thyroid stimulating hormone. Remember, that's the one that's made by the pituitary. A high level of TSH means that the brain is saying, please, thyroid gland, make more thyroid hormone. So it's what pushes the thyroid to make more. So a high TSH means you don't make enough, like you would be hypothyroid. A low TSH, we call a suppressed TSH, means that your brain is trying to tell your thyroid gland to make less thyroid. So that would imply that you have hyper or too much thyroid. So you got to measure TSH, and you have to be able to interpret the results properly. So what would be the ideal TSH? Well, similar to what a woman would have if she's ideally going to be fertile or pregnant, which would be 1 to 2.5. But if you look at the reference range, or what is looked at, it will often go up to 4.5 or 5. And some endocrinologists don't even treat unless it's over 10. Now, those of us in functional medicine look for optimal, not just reference ranges, which is like 95% of random people tested. So if possible, the goal would be to keep your TSH in that range of, say, 1 to 2.5. Now, the other thing that you want to measure would be free T4. That would be unbound, because you don't want the total, you want what's available. So that's free or unbound. So we call it free T4 and free T3. Now, because we are women, we're talking about here, there's a high incidence of autoimmune thyroid Hashimoto's, hypothyroidism, autoimmunity. So you want to measure anti-TPO and thyroglobulin antibodies. And those are not standard. They're not measured anywhere near as much as they should be. When a woman has impaired gut barrier or leaky gut, which becomes so prevalent in postmenopausal women and transitioning women into the menopause, it increases the risk of all autoimmune conditions. The number one most common one is Hashimoto's, autoimmune thyroid. Please get your antibodies for Hashimoto's tested. And then there's reverse T3, which is like the blocker that the body makes to slow metabolism. I don't get that on everyone, but if there's a question and you're wondering if under like a lot of stress, if the patient or yourself is having a lot of stress, you might want to measure reverse T3. If it's very high, it means that the body is purposely trying to suppress the energy ability of the body in terms of trying to conserve energy. That is like the body's response to a famine or a severe stress. So that would be useful in some circumstances. Now, say you have all these tests measured and you have a normal T4, but a suboptimal or low T3. That is when you want to think, why is the T4 normal but the T3 low? That could be because you're insufficient in certain micronutrients like zinc and iron and selenium. That's why you want to know. You don't want to just prescribe thyroid. You want to try to fix the thyroid. And you want to look at estrogen levels as well. By the way, really high estradiol. This came up in a question I saw. If someone is overdosed on estradiol, which we don't want anything too high, we don't want anything too low, we want it just right. If someone is overdosed on estradiol, it can actually suppress and lower the production of thyroid. So that's an important, that's because they're so interconnected, these hormones. So you want everything just right. So if the T4 is good and the TSH is good, but the T3 is low, you have to think, why is this conversion improperly happening? Think micronutrients first. Think leaky gut. If they're eating the proper foods and they're not absorbing the nutrients, that can be the problem. Also, liver disease. So a lot of the T4 is converted in the liver to T3. So look for things like non-alcoholic fatty liver disease, which is changing its name, but I'm going to stay with the old one for now. So those are things to look at. That's really important. If someone has hyperthyroidism, then you get TSI, thyroid stimulating antibodies. We're not going to do a whole big thing on Graves' disease or hypothyroidism right now. But if someone has really suppressed, naturally they're not on thyroid, but their level is very low, then you want to think about Graves' disease. That's autoimmune hyperthyroidism. Now, just a few words on thyroid hormone therapy, because so many of you will or are now hypothyroid. And why is that? Because of all the things I said, because you're female and because you may be going into menopause, your thyroid gland itself is aging, and you don't have enough hormones being produced for the thyroid to be functioning properly. I want to make a side note that because low estrogen can cause poor function of the thyroid receptors, even if you test normal for thyroid hormones in all the different testing, but you still have every symptom of low thyroid and you just don't know why, it can be because you don't have enough estrogen to maintain the function of the thyroid receptors in an optimal fashion. So you got to think about all these things and the complexity. Now, in terms of thyroid hormone treatment, once you are over 60, you don't want to use a desiccated thyroid product like NP or Armour Thyroid because those come from an animal. They are a natural product for an animal, not for a human. They have a different ratio of T3 to T4. Now, I told you T3 is the active form that actually acts on the cells to create the thyroid result, whereas T4 is like the money in the bank. It's just sitting there waiting for when you need to convert it into cash, which is T3. So we don't want to give too much T3, especially when you're over 60. It can trigger atrial fibrillation, like tachyarrhythmias. It can also cause bone loss. You don't want to promote osteoporosis. So you don't want to suppress the TSH. You don't want it to get too low because you don't want to overtreat with thyroid. And many women, especially as they age, but even below 60, will get overdosed on T3 with the desiccated products. I know they're natural, but they're not natural for a human. I used to use them a lot. I have moved away from them in most cases. If someone is on them and they're doing great and they're under 60, I'm not going to change them. But I don't want to start women now on a desiccated thyroid product because they're not time released. You can't control how they're going to dissolve in the stomach and get absorbed, and they have too much T3. And you don't need to do that in most cases. If you give T4, which is bioidentical thyroid for a human, it should convert properly from T4 to T3 as is needed. And if it doesn't, then you got to try to figure out why. And short-term or possibly long-term, you can give separately T3. The brand name is Cytomel, and you can give that so that they're not hooked together, whereas in a desiccated thyroid product, you get a fixed amount of T3 and T4, which you cannot change. When you give them separately, you can tailor make it to what that individual needs. And many will not need T3 once you make sure that they have all the right nutrients on board, their gut is functioning well, their liver is functioning well, their kidneys are functioning well. They'll make that conversion properly. And also work on stress. If you're very chronically stressed, which many women in menopause are, the stress will also suppress the conversion of T4 to T3. So you got to work on the root cause, ladies. You want to find out why that conversion isn't optimal. Don't just throw T3 at people if you don't need to. We want to fix the root cause. And sometimes you do need to give T3. You just don't want to give it if you don't know why it's low. At least try hard to figure it out. And you don't want to push T3, especially in an older woman. You may give her osteoporosis. You can also trigger, like I said, arrhythmias and atrial fibrillation. If you hyperthyroid someone, if you create hyperthyroidism by overdosing them at any age, you will promote loss of bone. There is such a thing as too much of a good thing, whatever it is. You can overdose on any hormone, including thyroid, including estradiol. We want to do optimal hormone production and optimal hormone therapy when we need to add that into the mix. So it's a complicated story, menopause and thyroid. But remember, women transitioning and thereafter in menopause have really high rates of thyroid disease. Make sure if you're the patient, you get screened. And if you're the physician, you screen your patients because you're going to find a lot of this problem. Look for root causes, work on them. And when you give hormones, give as much as possible the bioidentical T4, supplement additional T3 as you need to, and gingerly use the desiccated thyroid and not in women over 60. Thanks so much. I know it's complex, but it's a good start, I hope.